to be talking about platelet-rich plasma and that not all PRP or platelet-rich plasma is created equal. So we're going to do first a quick review. Blood has different components. You have your liquid component of the blood, which is your plasma, and then you have these solid components, which are the cells. You have your red cells, white cells, and then your platelets. So what are platelets? Platelets are the tiny cells in your blood that are the first responders to an injury. They get activated in response to an injury. As most of you know, platelets will aggregate and form a clot to stop bleeding, but more importantly, they secrete numerous growth factors which are critical for healing. So what is PRP, or platelet-rich plasma? It's where we take a sample of a patient's blood and we place it in a centrifuge to concentrate the platelets out of that blood sample. So the centrifuge will separate the cells based on the weight of the cells. So the heavy cells are the red cells, and they go down to the bottom of the tube. The platelets are in that white layer in the middle, and then the plasma is that yellow layer on top. So if we take that concentrated platelet layer plus the plasma, we have platelet-rich plasma, or PRP. So clinically, what do we use PRP for? Well, one of the most common indications is for our chronic tendon injuries. So our partial tendon tears or chronic tendinopathy, which is a degenerated damaged tendon. These injuries occur from overuse, aging, and trauma. A lot of times these tendon injuries fail to heal because they occur in an area of the tendon that has inadequate blood supply. So the body is unable to heal that tendon injury. So we can use PRP and inject it directly into the tendon injury to jumpstart that tendon healing and start that healing process. So it can actually heal the injury and be a more permanent solution, not just a temporary fix. We also use PRP for joint osteoarthritis. It can be very effective for arthritic pain. PRP helps to improve the joint microenvironment, so it will reduce inflammation and decrease the number of harmful proteins and cells that are causing pain and cartilage loss. So it's really reversing the toxic joint environment. It promotes healing of injured areas of cartilage and bone and slows the degenerative process. So it can really modify the disease. Now, PRP is really a better option for chronic tendon injuries as well as joint arthritis as opposed to cortisone. And multiple studies are showing this. PRP is really going to give longer-term pain relief. Cortisone can help, but relief is typically short-term. For joint arthritis, PRP not only helps the pain, but improves the cartilage health, whereas cortisone can help the pain, but it actually is detrimental to the articular cartilage. There are more and more studies confirming that cortisone can actually accelerate cartilage loss. And then for our tendon injuries, PRP can actually heal the tendon injury, whereas cortisone may help temporarily because it reduces inflammation, but it's harmful to the tendon. It can actually weaken the tendon and increase chance of tendon weakening and tearing or rupture. Numerous professional athletes have been using PRP for years, so it's really standard of care in orthopedics for the professional athlete world to enhance injury healing. Now, for those of you who are convinced that PRP may be a good option for you, you have to know that not all PRP is the same. Depending on which system you use, which clinic you're going to, there may be good PRP and there may be not so good PRP. There are currently more than 64 different centrifuge systems on the market, each producing a different type of PRP. This picture is an example of PRP produced from a single patient's blood, but using 7 different PRP centrifuge systems. And you can see how different the PRP looks depending on which system is used. Each one produces a different profile of PRP. So what are the variables in PRP that we can look at, and what are these systems producing? One is looking at the platelet recovery. How much of the platelets can that system recover from that blood sample? Ideally, we want a system that can capture 80% or more of the platelets in that blood sample. Some systems are weak and inefficient and can only capture less than 50% of the platelets in the blood sample. Next, the most important thing is platelet concentration or platelet dose. So what factor increase over baseline can we get with a PRP system. Typically, we want a system that can concentrate the platelets at least 5 times over the baseline platelet concentration in your blood. Some systems are very weak and can only concentrate 1 or 2 times over the baseline. And then we can also look at platelet dose. What's the total number of platelets that we can capture using a PRP system? We're seeing a lot of the more recent studies are showing that we need platelet doses of over 5 billion platelets in a PRP sample to be effective for treating joint arthritis. And then what's the purity? We look at the purity. How pure can we make that PRP? How can that system remove, capture all the platelets, but also remove the red cells and remove the white cells that we don't want in the platelets, in the PRP? So I'm going to go over a couple studies, recent studies, that have looked at platelet dose and how it correlates with clinical outcomes. This was a study that was just published last month, so fresh off the press, published in Arthroscopy, March 2024. And it showed that higher platelet dose correlates with better outcomes when treating knee arthritis with PRP. So this study was a systematic review, looked at 29 randomized controlled trials that compared PRP to other injection therapies for knee arthritis. The majority of the study showed positive outcomes for the PRP group compared to the control groups. But there were 3 negative studies where PRP was not shown to be better than the control group. So the authors looked at these negative studies and the positive studies to see if there, why were these negative studies, why did the PRP not work? So they looked at platelet dose, and in the positive studies that showed that PRP was helpful, the mean platelet dose was 5.5 billion. And then in the negative studies where PRP didn't help, the PRP dose was much lower, only 2.3 billion. So they concluded that the improved clinical outcomes in the positive studies is probably related to the platelet dose. They think in the negative studies, these patients may have been underdosed, so their PRP didn't have enough platelets to show a positive effect. And then this is another study just recently published in February 2024 in the Orthopedic Journal of Sports Medicine. Was a randomized controlled trial looking at 99 patients with early knee arthritis treated with PRP, and they followed them for 6 months. The first group received 4 milliliters of PRP with an average dose, platelet dose of 2.82 billion platelets. The second group, Group B, received double the amount of PRP. So they had 8 milliliters of PRP with an average platelet dose of 5.65 billion. It was the exact same system, same PRP, but just double the number of platelets. Both groups showed improvement, significant improvement compared to baseline, but the results were significantly better in the Group B, the group that received the higher platelet dose compared to Group A, which received the lower platelet dose. And at 6 months, the patient satisfaction was 96% in Group B with the higher platelet dose compared to only 68% in Group A. So again, another study confirming what we've thought for years is that higher platelet dose correlates with better outcomes, at least for knee arthritis. Most experts now are shooting for that 5 to 10 billion platelet range in the PRP when treating an arthritic joint. Now, authors have looked at the different PRP systems, trying to determine, what kind of PRP are we getting? Are we getting enough platelets in the PRP? This first author, Magellan, looked at 36 different PRP systems and found a huge variation in the type of PRP produced depending on which system was used. He saw that 56% of the systems produced PRP doses that were below 5 billion, and 64% produced PRP that was less than 5 times baseline. So a lot of the systems on the market out there are producing PRP that doesn't give you enough platelets to get to that 5 billion platelet count that we want for knee arthritis. Another author, Fadudu, also analyzed 33 different PRP systems and found very similar findings. A very wide range of different PRPs, a lot of them producing weak PRPs with the platelet doses that weren't consistent with what we want nowadays for joint arthritis. This is a table from a clinic in Canada, again, looking at the different PRP systems. And this section right in the middle, or with the red arrows, shows you the factor increase over baseline of the PRP, so how many platelets they're getting in the PRP. And it was interesting that 5 of the systems that they studied were producing PRP with a factor increase of less than 1. So that means that the PRP actually had less platelets than their baseline count in the blood. So you're actually losing platelets with these PRP systems. 5 systems that are on the market. And so these systems really should not be calling what they're producing PRP, because you're not concentrating the platelets, you're losing platelets. So these systems are actually producing platelet poor platelet poor PRP. So not good systems for use in orthopedics. So what is the ideal PRP? So again, based on some of these studies and what we know, we definitely want high concentration of platelets, at least 5 times baseline. For joint arthritis, we're shooting for that 5 to 10 billion platelet dose, total platelet dose. For tendon injuries, we don't need as many platelets, and we don't exactly know the exact number of platelets that we want for a tendon injury, but based on the basic science, we're shooting for a concentration of about 1 million platelets per microliter, or 1 billion per milliliters per milliliter. And more than that is not necessarily good for tendon injuries, at least based on the science. We also want PRP that is deplete of red cells. We want to remove the red cells from the PRP. Red cells are not necessary. They don't really have any useful function in the PRP, and it can actually be detrimental to the joint cartilage. And then what about the white cells? For joints, we definitely want to remove the white cells, specifically the neutrophils, which are the inflammatory catabolic white cells. For tendons, there's still some controversy whether or not the white cells can be helpful for tendon healing, but in general, we try to remove all the neutrophils, which are the catabolic inflammatory white cells, but keep the monocytes and the lymphocytes, which are the white cells that may be beneficial for healing. So what kind of PRP am I getting? Well, when you go to these clinics, unfortunately, you don't know. You don't know what system they have, what system they're using. If you know the name, you don't know what concentration of platelets you're getting or what dose of platelets you're getting. So unfortunately, the only way to know for sure is by using a cell counter. So a cell counter is a machine that can count the number of cells in your blood sample or your PRP. And it's really the only way to confirm how many platelets you're getting in your PRP and how concentrated you're getting it. It can also quantify the number of red cells and white cells. So if a patient comes in for PRP at our clinic, we take that sample of blood, put a few drops in the cell counter, we can count the number of platelets at baseline. So the number of platelets in their blood, the red cells and the white cells. After we produce the PRP, after the centrifuge, we put some of the PRP into the cell counter, and we can count the number of platelets in the PRP, and we can see how concentrated we've gotten. We can see the total dose of platelets we're delivering, and also quantifying that we've removed all the red cells and removed all the inflammatory white cells. So cell counters are very useful, but unfortunately, most clinics that are doing PRP don't count cells. They don't have cell counters. You really have to go to a clinic that specializes in PRP to really, if they have a cell counter, you're probably getting good PRP, but unfortunately, most of the clinics in the area do not count cells. So if they don't have a cell counter, there's other ways you can figure out what kind of PRP, if you're getting good quality PRP. So there's some clues you can look at just based on, and you can ask these questions to the doctor if you're getting PRP. One of the things you can look at is what color is your PRP. If it looks like blood on the right, that is an outdated system. Most of the PRP systems now remove the red cells from the PRP. You want your PRP to look yellow, like pineapple juice. Second, how much blood are they taking for the PRP? How much is the blood draw? To get to that 5 billion or plus platelet dose, or 5 times baseline, you really need at least 60 ml or 60 cc of PRP. So you want to fill up the tube on that right is a 60 cc syringe. You want to get that much blood to get the platelet dose that you need for treating an arthritic joint. Some of these systems are only drawing 10 or 15 cc's of blood, and that's really not going to give you enough platelets for treating a joint. Those systems, even if those systems can capture 90% of the platelets in that blood sample, it's still going to be too low. You're not going to get enough platelets because it's just not enough blood. So you really need enough blood to get the higher concentration, higher doses of platelets. And then if you're injecting two joints, let's say someone comes in with bilateral knee arthritis, and you're injecting two joints, you need to get double the amount of blood. So we actually use two kits. If you try to inject two, you can inject two joints with one kit just by getting more plasma, so increasing the volume, but you're basically splitting the amount of platelets in half, so each knee is going to get underdosed. So you want to get more, the more places you're injecting, you need to increase the amount of blood you're drawing. And then, is it a single spin system or a double spin system? So a double spin system is going to give you the higher quality PRP with higher platelet dose, higher concentration, and more pure. Single spin system can be good, but the platelet doses are definitely usually below 5 times baseline. So you want a system that is a double spin. So if a clinic doesn't have a platelet counter, you can ask them these questions. You know, do you have a double spin system or a single spin system? How much blood are you drawing? And then, you know, what color is my PRP going to look? And you can ask them these questions. That'll give you a clue as to, you know, what kind of quality PRP you're getting. Now, how are you getting the, you know, how are you hitting the target? Where, you know, we want to do these injections with image guidance. That's really standard of care. So we use ultrasound or fluoroscopy to ensure that that PRP is going to make it to the target area. Multiple studies confirm that image-guided injections are more accurate than blind injections. Blind injections are no longer standard of care in our field. There are still some doctors doing blind injections. Usually it's the older orthopedic surgeons who have been doing it for years, and they don't feel that they need ultrasound for the injections. But the studies show that it's definitely more accurate if you use guidance for the injections. So we like ultrasound for all our peripheral joints and soft tissue structures. The ultrasound can visualize the tendons, ligaments, bursa, nerves, and also we use it for most of the peripheral joint injections. Not only can you see the needle, but you can see the pathology that you're targeting. So if you have a small tendon tear, you're not going to get a PRP into that tear unless you use ultrasound to visualize the tear and see the needle entering the pathology. So very useful for injecting tendon or ligament injuries where you want to get the PRP directly into the area of the injury, or if you're using it for very small joints, you know, a small joint in the hand or in the foot, very difficult to get a needle into that joint, especially if it's arthritic, you know, without any guidance. Here's an example of using ultrasound to inject the knee. So the ultrasound is placed over the suprapatellar recess of the knee. And then under ultrasound, it looks like this. We can see the needle coming in from the left side. That suprapatellar recess of the knee is filled with fluids. We place the needle into the recess using ultrasound. We aspirate the fluid out and inject the PRP. And then we use fluoroscopic guidance for other injections. So all our spine injections uses fluoroscopy. Fluoroscopy is basically like a live low-dose X-ray to help guide the needle into the targeted area. So on the left, we see 3 needles going into the bottom 3 lumbar discs. Once we're in, we inject a little bit of contrast, and we can see on the X-ray confirming that the spread is going into the targeted area. In the middle there, we see an injection of a hip joint using fluoroscopic guidance. That needle is coming in from the right, and we see the nice spread of contrast around the joint capsule. Usually we use, a lot of times we'll just use ultrasound for hips, but you can use fluoroscopy as well. The picture on the right is a picture of an injection of an ACL, anterior cruciate ligament. That ligament's a deeper ligament in the knee, difficult to see fully with ultrasound, so we like fluoroscopy to target that specific ligament. And who is doing your injection? You know, you can look at all this stuff on the website, look at the physicians that are doing the injections, you know, what's their specialty, what's their training. After medical school, most doctors will do a residency. Residency is where we do uh, uh, 3, 4, 5 years of specialty training in a specific specialty that you want to go into, whether it be orthopedic surgery, physical medicine and rehabilitation, or so forth. After residency, you can start working, or you can do a fellowship. So someone says that they're fellowship trained, that means they've done an extra year, sometimes 2 years of subspecialty training in a specific field. So you can do a subspecialty fellowship in sports medicine, spine, pain. That just means that you've taken a whole extra year to train and learn these more advanced techniques in that specific field. And then after all your training, you could become board certified. That means that you've done all the required training and passed the tests to become board certified. For doing these injections, I think for these image-guided injections, the specialties that I think are the best at performing these would be our specialty, physical medicine and rehabilitation, with a sports, spine, or pain fellowship. Family medicine physicians can do a sports medicine fellowship as well, though they're usually very well trained with using ultrasound and doing peripheral joints, but most of the family medicine guys don't do a lot of spine work. The anesthesiologists also can do a pain fellowship and learn all the spinal injections, but they may not do as much of the peripheral joint work. And then radiologists can do interventional fellowship, so they're an interventional radiologist and can do these injections as well. Chiropractors and naturopathic doctors cannot perform injections, at least in California. So they typically aren't going to be performing these injections. What about physician's assistants or nurse practitioner? They can perform injections. However, it's going to be a wide variability of their experience. During schooling, most of these PAs and nurse practitioners aren't going to be getting a lot of training in doing joint injections with guidance. So a lot of their experience is going to become during when they're working. So if you have an orthopedic PA that's with an orthopedic group that's been doing it for 10 years, they're probably pretty proficient at doing a joint injection using ultrasound. But if they're fresh out of training, they're still learning. So you're going to have a wide variability of whether or not they are qualified to do certain injections. If you're doing something a little more complex, like a rotator cuff tendon, they probably don't have the training to do, the more advanced type of injections for certain tendons and ligaments. And then what type of clinic are you going to? Most orthopedic groups or orthopedic surgical groups will now offer PRP for those patients who don't need surgery. A lot of times the surgeon won't be doing the injection, it will be the PA. Or sometimes they'll have a specialist in the office, a non-surgical specialist that will do the injections for the surgeon. But you can't really be sure about the quality of PRP you're getting. Most of these, I can guarantee most of these orthopedic groups are not going to have a cell counter to count cells. And then you don't know what PRP system they're using. A lot of times, they don't have a vested interest in making sure you have good quality PRP. They're looking at, and I know this because I worked at an orthopedic group and I was prompting them to get a better system. But they're concerned about the cost of the system, how much the kits cost. Is it easy for the medical assistants to process the PRP? So the quality of PRP you may be getting may not be ideal. And then you have the chiropractic model. There's been this model where chiropractors will hire a medical advisor, usually a retired physician, so they can become the medical supervisor of the group. And then they hire PAs and nurse practitioners to do the injections of PRP or what have you. And that model, I question. I don't think it's an ideal situation. I don't know the type of quality of PRP you're getting or the injection capability of the people that they hire. So I would try to avoid that model for these injections. I joined San Diego Orthobiologics about a little over a year ago, and I think this place has, and this is one of the reasons I came here, it has, I think, the best processing system for PRP out there. They don't rely on a specific system. They have a manual processing system so they can customize a PRP depending on the condition. At my old group, we went through, I think, 5 different PRP systems because as times changed, we saw that certain PRP may be better for certain conditions. If you have a certain system, you're kind of stuck with that type of PRP, and then you have to get a whole new system if you want a different type of PRP. Here, we can actually customize a PRP depending on the condition. Most of our standard PRP has a double spin protocol. We're always getting to that 5 times baseline, 5 to 10 billion platelet count, and we confirm that with our cell counter. So we know before the injection, we know exactly how much to inject and how many platelets we're getting with each injection. And then if we're doing like a smaller joint where we want super concentrated PRP, 10 times baseline, we can produce that if needed. We still have a single spin protocol for certain conditions that we'll use. So very, customizable processing system and cell counting. So a very excellent system here. All the physicians here, our specialty is physical medicine rehab. We've all done residency in physical medicine and rehabilitation. We're all fellowship trained in spine and sports medicine, and then we all have multiple board certifications and subspecialties as well. So as most of you know, PRP is still not covered by insurance. So you're paying out of pocket for these procedures. You want to do whatever you can to make sure that you're getting the best chance of a positive outcome. So the keys to success is, one, I think you got to look for a clinic that specializes in PRP and regenerative medicine. That's going to be, if they have a cell counter, you're likely going to be getting good quality PRP at that clinic. Two, you want to make sure you have an appropriate diagnosis. If you go to a clinic and they're ready to inject you without examining you, without looking at the imaging studies or ordering an MRI, then that's usually a red flag. Three, again, you want good quality PRP with a good platelet dose, ideally cell counting to confirm what you're getting. And then lastly, again, image guidance with the injections. You want to make sure they're injecting using image guidance and they're trained to do that. All right, so that's my talk. Thank you. I'm happy to answer any questions now. So you can type questions. Anyone that has questions can type them, and I will answer them to the best of my ability. Okay, we have a question here. What can be done nutritionally to prepare in advance for the PRP procedure? Good question. One of the things we do at our clinic is blueberries. We have you eat lots of blueberries the days leading into the PRP procedure. There have been studies that show that blueberries can help enhance the numbers and quality of the platelets in your PRP. And how far in advance? We typically say within 24 hours, but more than that could be better, but we don't know. We also like you to make sure you're hydrated the day of the PRP procedure, not only for the blood draw, but in general, have enough hydration on the day of the injection. Are you doing stem cell too, or just PRP right now? Yes, we are doing stem cell procedures. I would say 80% of what we do is PRP because most of the data is for PRP, but we are doing the FDA-approved stem cell procedures using fat, microfragmented fats. We do a lipoaspiration procedure to harvest the mesenchymal stem cells from the fat, and we can inject that for larger tendon tears or more severe arthritis. And the other option for a stem cell procedure is bone marrow, using your own bone marrow. So we do a bone marrow aspiration. We concentrate the mesenchymal stem cells out of that bone marrow and inject that into whatever structure we're treating. Let's see, what else do we have here? Do you withdraw the blood and inject on the same day? Yes, it's required that we do that to be in compliance with the FDA guidelines. We do the blood draw process, centrifuge the blood sample. It takes about half an hour for the total processing, and then inject the same day, usually half an hour later. Does this work for a generation of muscle? For muscle injuries, actually, we like to use the studies, at least the studies have shown that for muscle injuries, we use platelet poor plasma. PRP can be used, but there are studies that suggest that PRP may cause more scarring, and platelet poor plasma still has lots of growth factors. And we think that for muscle injuries, platelet poor plasma is better. So usually for muscle injuries, we like platelet poor plasma. For tendon injuries or ligament, we like the platelet rich plasma. I have bone on bone in my knee. Will PRP work for me? The chances, if it's truly bone on bone, then I would say no, PRP would likely not work. However, I have had patients who are too old, they're not going to have knee replacement, they have severe arthritis, and I am doubtful that the PRP can work, but they still do well. I think it works in that setting because it's changing the microenvironment. The pain in knee arthritis can be mechanical, bone on bone, or it can be more biochemical. Inflammation, the different cytokines that are causing pain and cartilage loss are high in a patient with arthritis, and PRP can reverse that microenvironment, and sometimes it can still help the pain even with bone on bone knee arthritis. So I wouldn't say definitely it can't work, but the chances are likely not. Can PRP be combined with hyaluronic acid? If so, why or why not? Good question. There have been several studies that have looked at that exact question. Combining PRP with hyaluronic acid, can that be helpful? And the answer is it's debatable. We don't know for sure. There are definitely some studies that show that PRP with the hyaluronic acid is better than PRP alone. And there are studies that show that adding the hyaluronic acid to PRP is not better. So I would say it's controversial. We can definitely do it. We don't typically do it here at our clinic just because the data doesn't point that it definitely is helpful. But and most insurances don't cover the hyaluronic acid anyways. So usually it's another extra out of pocket cost to the patient. So typically we're not doing it at the clinic, but it can be done. Let's see what else we have here. What does PRP do for degenerative disc disease, stage 4 severe? Does it result in repair or just reduce inflammation? Injecting PRP into severely degenerated discs will not regenerate the discs. The ideal patient with disc disease for PRP is someone who has preserved disc height with just tearing of the disc, annular tears of the disc. That's where PRP can actually potentially heal these annular tears. But if that disc is already severely degenerated, PRP or even stem cells usually not going to be good enough to regrow that disc. However, PRP still can help in certain situations. There are newer protocols for spine that we're using where we're not putting the PRP in the actual disc. We put it into the other areas of that segment. So we inject the joints, the ligaments of that same segment to help stabilize that segment, because we suspect that some of the pain with degenerative disc disease is due to micro instability. So that disc is kind of moving and causing pain. So we can try to stabilize that segment by injecting PRP into the joints and into the ligaments, and sometimes into the space around the disc that can help pain and help stabilize those degenerated segments. It's a newer protocol. We are seeing some positive results, but it's still considered experimental. Definitely a good option versus getting a lumbar fusion, which would be the other option. For a knee, PRP, I wouldn't say regrows cartilage, but it's changing that joint microenvironment, so improving that microenvironment of the joint. I think there's good evidence suggesting that PRP can actually slow the degeneration, so it can preserve it at the same level, but I wouldn't say it's reversing the arthritis. It's reversing the microenvironment and all the inflammatory chemicals and mediators, but it's not regrowing cartilage and reversing the arthritis per se. But it can, if you catch the knee arthritis at that mild to moderate stage, then hopefully we can keep you there and prevent you from, getting worse and progressing to severe arthritis. Which injuries do better with PRP or stem cell? In general, PRP is what we're using for mild to moderate arthritis, smaller tendon injuries, stem cell, or using the microfragmented fat, sometimes bone marrow, we like for our larger tendon injury. So if you have a large tendon tear, PRP, if you inject that into that large tendon tear, it's just going to spill out of the tear and not stay there. We like the fat because the fat will actually produce a scaffold and fill that gap and potentially heal the tear. With more severe arthritis, PRP is not as successful, and that's where stem cell, like fat or bone marrow, may be better. Again, we're still collecting data to see how well it works for the severe cases, but in general, most experts would say when it's severe arthritis, fat or bone marrow. Mild to moderate, PRP. And then with the tendon injuries, larger tendon tears, fat would be better than PRP, but the partial small tear is definitely PRP. The portion of your bone structure is bone on bone, how much, if any, of the PRP will make it around the bone to provide some type of cushion? When we inject into a joint that's bone on bone, it's going to get into the area, it's going to get around the whole joint, but I wouldn't say it's going to provide any cushioning. So it's not going to reverse the bone on bone. It can only help the pain by improving the joint microenvironment. Do you work on compression fractures? Acute compression fractures, no, we don't. That we will treat usually with rest, bracing, and then physical therapy. Most of these get better without any further intervention. The patients who are in severe pain and are not improving with rest and bracing, there's a procedure called hypoplasty that we don't do here, but a lot of surgeons will do that. Where you put needles into the fracture and put a balloon in to reduce the fracture and get some height back, and then put cement in to stabilize it. So we don't do a lot of work with acute or subacute compression fractures. A patient who may have a more chronic compression fracture and pain related to deformity, it's possible that some of the stuff we do can help, but we don't do a lot of work with compression fractures. How much would be the cost to inject 6 billion platelets in a knee? Usually it's, we're using one kit. Our price is around $1,700 for one knee. And that includes drawing the blood, doing the processing, concentrating the platelets, platelet counting, and then the injection with image guidance. Okay, let's see what else we got here. Another question on cost. Again, about for a single area, for a knee, a shoulder, it's typically around $1,700 the cost for a PRP injection. That would include, like if we're injecting a shoulder, a lot of times we're not just injecting one tendon, we're injecting sometimes, the different tendons in the shoulder that are pathologic that we think are causing pain. So that would include sometimes a joint, sometimes a tendon, sometimes the bursa. That cost kind of includes everything for that region. For an arthritic knee, what is the location of the injection? Typically, we use ultrasound and approach it from the superior lateral aspect of the knee. So here's the model of the knee, here's the outer part of the knee. So usually we put the ultrasound like that, and we can see the suprapatellar recess, which is the top portion of the knee joint that connects to the rest of the joint. So usually if there's fluid there, we'll see it. We use ultrasound to guide the needle in the joint, aspirate and inject the PRP. Occasionally, we'll go this area just on the inner side of the patella. That's a medial infrapatellar approach. But the approach you use doesn't really matter. We don't really go based on where the pain is. We go based on the ultrasound showing that we're getting in the joint. So if you inject this here or here, it's still getting to the entire knee joint. How successful is PRP for spine osteoarthritis? Good question. We don't have a huge amount of data for spine in the literature, at least. We know that for knees, a lot of the studies are showing for mild to moderate knee arthritis, we're getting over 80% success. For spine, there's not as many studies, but depending on the situation, I would still say that there's over 50%, maybe 70% chance that we're going to help the pain, improve stability, and hopefully prevent surgery. It all depends on the situation and what the symptoms are and what the MRI shows. But we're definitely still seeing positive outcomes for spine arthritis. Someone's asking about success of using PRP for arthritis in the hands. Yes, we can definitely use it for hand arthritis. I would say the most common area in the hand would be the thumb CMC joint. Very common area to get arthritis. We inject that often. Those don't respond as well as knees. If it's severe, it can help, but definitely not as successful as a knee injection. We can inject some of the other joints if they're symptomatic, with varying degrees of success depending on how bad the arthritis is, but definitely not as successful as I would say as knees are. How many shots for moderate knee arthritis? Typically, we're doing one injection. You can do a series of 3. The data 1 versus 3 is debatable. There are some studies that show 3 is better than 1. Some studies show that 1 is you only need 1 injection, not 3. So it's kind of debatable. I would say that in Europe, their protocol is to inject usually a series, so like usually 3 injections. But most of the systems that they're using in Europe are these systems that are producing very low dose platelet count. So usually 2 to 3 times baseline. So it's possible that they need those 3 injections because their platelet dose is lower, so they need to stack them a series of 3 versus if you have 1 injection with high dose platelets, hopefully it's just 1 and done. Let's see here. Okay. Okay, here's a good question. For an arthritic knee, what is the length of time usually needed to see some result, if there will be a result? I would say it's not like cortisone. Cortisone, you're feeling better within a week or 2. PRP, you got to be patient and wait. I would say the earliest we typically start seeing improvement is about 4 weeks. I've had a few patients usually at 2 or 3 weeks where they start seeing improvement, but typically 4 weeks to start seeing some improvement. That improvement continues gradually up to that 8 to 12 week mark. Occasionally, we see patients who, and we don't know why, but some patients won't turn the corner until that 6 to 8 week mark. So if it's 6 weeks in and you're not improving, I wouldn't give up hope because there are some patients who start improving later down the line. And we like to wait the full 3 months to really see what the final outcome is. Question, do you numb the area before injection? We definitely numb the skin. We numb the skin before placing the needle for the PRP injection. We don't like using a lot of numbing where we're putting the injection, only because a lot of these numbing agents can kill the platelet, so they're toxic to the platelet. So we don't try to put a lot of numbing around the area that we're injecting, especially if it's in a tendon. We can use some dilute numbing agents like ropivacaine. Ropivacaine has been shown to be, not to be toxic with a platelet. So we use dilute ropivacaine if an area needs a little more numbing. And then we don't usually mix a lot of numbing with the PRP, again, because it's not good for the platelets. And then when do you combine PRP and prolotherapy with dextrose? That's a good question. That's more of an art. There's not a lot of hard studies saying, we should do both and combine the two, but I've definitely had patients where, especially if we're treating instability, sometimes, one PRP, we're treating multiple ligaments when someone who's unstable, like someone who has SI joint instability. We'll do PRP to the ligaments, sometimes in the joints, and then sometimes we'll follow up with some prolotherapy to get some additional effect. But there's not any hard science as to, combining the two and when to do, that. But a lot of times I'll start out with the big gun, the PRP, and then follow up with prolotherapy later down the line to get more boost to the treatment for stability. What about neuropathy? We haven't used PRP really for neuropathy. There's not too much data that I'm aware of using PRP for neuropathy. So we don't typically treat peripheral neuropathy using PRP. I've heard of some doctors trying it, not sure what the results are. I haven't seen anything in the literature yet using PRP for neuropathy. Okay. Any more questions? I'll kind of hang out for a few more minutes to see if anyone has any burning questions to ask. But yeah, thanks everyone for joining. Hopefully you've learned something about PRP because yeah, a lot of clinics are offering PRP, but yeah, the quality and what you're getting, you don't really know. You go to these clinics and it's not like shopping for a car, because with a car you can evaluate the car, look at it, know what you're getting. With the PRP, you just go to the clinic and you get whatever PRP system they have. So you're usually not analyzing it like we are as doctors. So it's just good to know. So I think, again, to try to confirm or you're getting good PRP, go to a specialist clinic, see if they have a cell counter. If they have a cell counter, you're likely getting good PRP and they can confirm that. And then if not, then you can ask them these questions about their system. Is it double spin or single spin? How much blood are you drawing? You want 60 cc's at least for one joint. And then is it yellow? Does it look yellow, or is it red PRP? Some of these, you can ask those questions to kind of get a clue as to what type of PRP you're getting. All right. Well, I think we'll end it there. I hope everyone enjoyed the talk today. Hopefully you learned something. And if you need PRP, come visit us. All right. Thank you, everyone.